All right, it's just past 4 here on the Eastern Coast. I'm Jacob Kirsch, president of the North American Society for Cardiovascular Imaging. I want to welcome you all to this, our fourth webinar of the year, early May. I know people are busy. We're all dealing with a lot these days, so I'm glad to see that we have a nice turnout for the webinar, and hoping everyone is doing well and staying safe back home. Why don't we get started? I know Dr. Litmanovich wanted to show some cases, but she let me know that she was running a bit late, so I have her presentation. We saw some of those cases of her presentation last month, so we're going to try to finish those. And as soon as she joins in, is there anybody out there who wants to show some cases? We can start with one of you guys. So if you just want to go ahead and unmute yourself and request the presentation, we can do that.
Hi, it's Carol. I
Dr.
keep
Denny
getting muted
had some
again.
cases she wanted to share, or Dr.
Yeah.
Vargas? If not, I can
I've
start
got
with a
some
couple
cases.
cases. Hey,
Can you
Carol?
hear me?
Yes, I can hear you well.
Yeah?
Yeah.
Okay, sorry. Yes.
I'm gonna make you presenter now, okay?
So, okay.
And we'll see how this goes. Let's see, make presenter. Okay. You should get it. You should get a message.
Oh, it's asking me to, okay. It's asking me, did that work? No, it's asking me to open my preferences, my system preferences, sorry.
That's okay.
Okay. I'm not sure how to do this, so I might be having the same trouble as Karen did.
Okay.
My computer is giving me some privacy issues.
Okay. All right, let's see how I can take over.
So maybe someone else can go ahead and I'll try. I'm not sure how much more I can do here.
That's fine. Dr. Vargas, you have cases for us? If not, I'm trying to see how I can regain. All right. You see my screen again?
Yep.
Okay. Anybody else who may have cases want to give it a try, see if we can successfully connect?
So I can give it a try here, if okay, Jacobo.
Sure.
Although I have not shared a screen in GoToMeeting, so if I'm not able to do it and obscure the HIPAA data, then we'll have to. Well, let me give it a try.
Yeah,
okay.
It worked well for you last time, so you've done this. All right.
Okay.
I shared this.
Screen, main screen, all screens. All right. Well, I think I can't do it because I can't share a window. I have to actually share an application. So I'll get the case anonymized and I'll share in a few minutes. Okay.
Okay. So I'll start with my cases then. Perfect. Thanks, Greg.
All right.
All right. Okay. So everybody should be seeing my screen. Let me just get now my Osiris going here. So let me figure out which case to show first. All right, this is a good case, I think. Let's share this. Open up. There you go. Okay, and actually, this case, I had posted it the lateral view on Twitter in anticipation of this, and Dr. Alegria, and she is on the line, had some suggestions looking at the lateral. anything that catches anybody's attention here on the frontal. If not, I can go through it. So I'll tell you the story. This is a 44-year-old male with some shortness of breath, some chest discomfort during both rest and exercise. It kind of irradiated to the left shoulder and to the left arm, so it was kind of concerning. But again, young male, no significant history for cardiac disease. So this is a frontal view, the PA, and it looks somewhat unremarkable, I think. And when it was read prospectively, not much was mentioned here by the person who read it. And they repeated the frontal to get a better look at the costophrenic angles, but again, looks about okay. The lateral is very interesting though. Julia, do you want to make some comments since you already commented a little bit on Twitter?
Okay, to me, looks a little bit high density in the retroexternal area. Just here, can you see the points here or at the screen or not?
You're talking down
No,
here?
you cannot.
No, you're talking about the retroexternal here, pre-aortic?
Retroexternal.
Or here?
Here, where you are moving now. Yeah, just
okay.
there.
All right. So that's a very interesting observation. I'm gonna try to window it a little bit, make it a little bit narrower. There you go. And what I think what Julia is perceiving as high attenuation below behind the sternum here is probably actually normal, and it's a bit of a eye trick that really all of this below here looks pretty lucent. I mean, we see the ribs very well.
Yeah.
We kind of see the long markings a little bit here as well. It just looks odd that we have the discrepancy on density. So not so much that this is dense, but maybe all of this is a bit too lucent below the heart. Or the
yes, I agree with that.
And even here, it looks a little bit too lucent. We see very well behind the heart. Usually we don't see this well. But I mean, it may have to do with technique as well, but definitely on the lateral, it looks kind of different and odd. So patient, of course, was sent for a coronary CTA because of this, chest pain. But again, very young patient without significant risk factors. And unfortunately, I could not export all of the images. But this is what the frontal reconstruction of the heart looks like. And we see right below the heart this big hypodense mass-like structure displacing the heart cephalad. Pretty homogeneous, a few little wisps of soft tissue maybe through it. Here's a lateral view. It kind of looks like the lateral chest x-ray where we saw that very well-defined normal density structure, which was a heart, and then this hypodense structure here. So let's just go back to the lateral view, and you see again, you can tell that probably this is the bottom of the heart here, and this all that low attenuation mass. So it's interesting because this is really probably similar to the silhouette sign that we see in pneumonias that we used to see in which lobe the pneumonia is. If we lose that contour between two of the five radiographic densities, usually in the radiographs, we're talking about air and soft tissue. Here we're talking about fat and soft tissue. So we use that to our advantage to see there's a well-defined margin, there's a fatty mass below the heart. So, and I do have also, just so that you can see it here, there's what it looks in the axial plane right behind the heart. Again, there was a tiny little vessel here arising from one of the coronaries. It was from one of the non-dominant coronaries feeding into this big intrapericardial lipoma. Of course, we didn't know it was a lipoma at the time. We know it was a predominantly fatty mass that was taken to the OR, and then we know it's a lipoma based on the PATH specimen. really your differential considerations for a mediastinal fatty mass can be concerning, and that's why many times surgeons want to take them to the OR. We're talking, of course, of a lipoma, which these are very rare, and these fatty masses, intrapericardial fatty masses, are rare, but they would include also liposarcoma, which you want to make sure that you take care of. So lipoma, liposarcoma, germ cell tumors, which can be predominantly fatty, those are going to be the main considerations. And then in the pediatric population, lipoblastoma should be considered as well. However, like I said, these are all relatively rare types of mediastinal masses. So this is definitely the largest lipoma that I've seen. I've seen probably a handful or so, or a bit less, but this is by far the largest one. An incidental note is the patient did have an anomalous coronary on the CTA, but again, I don't have the full data set here, but there was a retroaortic circumflex arising from the right coronary cusp with its own ostia separate from the right coronary artery, and a retroaortic course, which is benign in etiology, likely not the cause of the patient's chest pain. It was probably related to the displacement and mass effect from this heart that was giving the patient some trouble. Patient has been doing well since. So that's one case. Any questions about that case? All right. This is an interesting case, very just show and tell, and I'll get some input from you guys. This is an older patient, came in with a mitral valve prosthesis that was had some issues with it, had gotten infected at some point, I believe. But anyway, it was not working well, and the patient went on to see the cardiologist, which suggested to do a repair, and eventually ended up in the structural cardiologist's office for the opportunity to have a valve-in-valve replacement. So let's look at how this is a pre-surgical or procedural images. By the way, if you want to learn more about pericardial lipomas, there's a great paper in radiographics on pericardial neoplasms by Dr. Vargas, who's on the call. So go check it out. It's a very, very nice paper. All right, so there's the coronaries. We see there's some filling artifact, mixing of contrast and non-contrast, and has blood in the left atrial appendage. This is an end-systolic phase. It was done in a similar phase as a TAVI procedure. And here we see the mitral valve and the leaflets with significant calcifications there. So in essence, creating some stenosis, and that required a valve-in-valve procedure. I did some thick MIPS that I want to share with you. So this one here, you can see this in a 4-chamber view, and you can see the valve there. And again, the valve is a 3-dimensional structure with 3 struts protruding into the ventricle cavity. It's difficult to see on echo, because echo being a 2-dimensional planar imaging, when they scan through the heart, it's hard to tell how much these valves really impinge into the LVOT. And when you look here at the 3-chamber view, or the outflow tract view, like the best one here, at least to me on this view, it seems like there's some important narrowing of the LVOT by at least one of these legs of the mitral valve, maybe just over 50% or so. So in this case, it's important to keep that in mind for pre-deployment. They're going to put a valve in there. The valve of choice that was placed here was a Sapiens 3 from Edwards, which has the valve is within a stented structure, but that is a non-covered stent. So I don't have a CT post, but just for you to kind of get an idea of where these legs, how they extend here. And then if we look at the X-ray post-procedure, which should be somewhere here. Here it is. So you can see how much of that stent actually protrudes into the left ventricular cavity and a fair amount into the LVOT. But like I said, this is a not covered, so there should not be a reason to create a significant gradient between the proximal and distal to the LVOT. So it seems like the patient is doing well, but it's important to always keep an eye on those LVOT pre-procedural imaging to make sure that the neo-LVOT doesn't get occluded too much and potentially put the patient at the risk for a valvular gradient at the level of the aortic valve. Any comments on this? You guys who have experience with percutaneous mitral valve procedures? All right, then I have another case. Somebody wants to mention something?
But I was going to say, when you're done, I can show a case, but please keep going.
All right, I have just one quick show and tell, and let's see. Is it this one or 70-some-year-old lady with a 72, I believe, severe heart failure, secondary to treated lymphoma, underwent radiation to the chest and chemotherapeutic. So it's probably a combination of the chemo and the radiation that has this patient on heart failure. So she was placed on an LVAD. She was placed on a HeartMate 3. Looking for the best sequence to show this. Came in with some shortness of breath, not feeling very well, some weakness. So here you see the efferent conduit out of the aorta, out of the ascending aorta going anteriorly. Here it is, looks fine. Here it is. Patient also had a mitral valve replaced there. You see the conduit that comes and connects. Here's the HeartMate 3. The conduit's going to come from below and connect into it there. We see it looks fine. And you can see the contrast within the conduit. That's important. You want to make sure that there's contrast in there, that it's not occluded. What we don't see is contrast within the efferent conduit, the one that connects into the left ventricle. So this was completely thrombosed. This was a thrombosed efferent conduit of the LVAD. A patient had to go into some anticoagulation to help her resolve that thrombus burden. So she was in the hospital while she was on that, and some additional supportive measures to help her get through it. So again, just a quick show and tell. Things to look at when you have a patient on a mechanical support, of course, is patency of all the conduits. There's a lot of literature on the angle of the efferent conduits and how it can actually abut the walls of the ventricles and partially occlude them or put additional pressure on it, which can predispose to thrombosis. So that's also something to make sure that you look at, that it's not abutting, the end of the conduit is not abutting or partially abutting the ventricular wall. Any comments from anyone? If not, we'll let Greg present his cases. And yes, no, this is not the most common. This is one of the where you see the thrombus, like Daniel says on the comments. Perfect, guys. All right. Let's see. Ready, Greg? I'm gonna find your name here.
Yep.
All right, go for it.
Okay.
Perfect.
Okay. All right. Okay. So this is a case that I found this I think is a valuable case to show because I've had 2 cases like this now, and in both cases it was poorly recognized what was going on. This is a woman who had a motor vehicle accident back in 1999, and at the time she had a traumatic pseudoaneurysm of the ascending aorta, and that was repaired with a patch, and that's sort of some of the irregularity that you see here. However, there was no recent imaging of this, so this is actually done several years after her accident. Why she came in and got a CTA was because she was presenting with hemoptysis. So you can see that she has all this ground glass in her lungs. It actually looks to, in some way, airway centric. See how there's some of that like very, very peripheral sparing, and it looks, you know, it looks like it's filling of the alveoli, and it is directly abutting her repaired aneurysm. Okay, so this is this patch repair area, and it is adjacent to that she has all that ground glass. What this actually is a person can have a pseudoaneurysm of their aorta, and when you have ground glass immediately abutting it, and it's in conjunction with somebody who's having hemoptysis, it is a fistula between the aorta and the pulmonary parenchyma. And that's actually what it was in this case. This patient went to surgery, and you know, this is extremely adherent because it's all inflamed. It's extremely adherent to the aorta, and it's, you know, part of the pseudoaneurysm in this patient is the visceral parietal surface. So surgeons have to be alerted that when they go in there, they just can't peel this thing off. They have to, you know, that would be disastrous. The patient would exsanguinate on the table. So this was actually treated with stenting. I don't have this, I have the stenting image, but I don't have that to show everyone. So they decide to actually treat this by stenting across the pseudoaneurysm, and the patient symptomatically improved. The one common thing, at least in the 2 cases in my review of the literature that you see with patients like this, is that the hemoptysis is usually episodic and severe. So a patient will really complain of really just severe, frightening hemoptysis that will resolve, and that has to do with the communication between the aorta and the lung parenchyma, you know, undergoing hemostasis, where you know, the bleeding will stop, and then something will happen, will reopen and gush, and they'll cough out all the blood, and then it'll stop again. So again, so it's a pseudoaneurysm or irregular wall to the aorta, use something like a penetrating ulcer with adjacent ground glass in a patient with hemoptysis, and just should, you know, that constellation of findings should be recognized as a fistula.
Greg, how do you explain all
Yes.
the other faint? Look, I mean, it's a small picture for him, but there's some other opacities, like nodular opacities. It seems like across both lungs. So is that just because
You're talking about in this area here?
Yeah. So that's all reaction to the inflammation.
No, this is actually blood coming from the aorta. So the blood.
Okay.
Yeah, so the blood comes into the parenchyma, and it's basically blood filling the alveoli, and then, you know, because the aorta is so high pressure that when this opens up, they get a large dose of blood, they cough a lot of it out, but so essentially it has the appearance of aspiration. Yeah.
Great case. Thank you.
Does that answer your question?
Yeah. Great case.
Okay. All right. That's all I have.
Perfect. Carol, you want to try again, or should we? Or has Diana joined?
I don't see Diana. I'm willing to try again.
All right, let's do it again.
Certainly after this is done, I can stay online and we can try and figure this out so I can do it next time.
For sure. All right, so I share with you, and if not, we can start going through Diana's cases here. So it's not a big deal, but there you go.
Am I there?
I see your screen. Yeah.
Okay. I don't know how to get rid of this.
That works. Just put it to the side. Perfect.
Okay. All right. So this is a case. This is a 72-year-old woman who, for some reason it's skipping to the bottom. Okay. This was given to me courtesy of one of my colleagues, Dr. Elena Pena. And this 72-year-old woman had a pre-op chest x-ray with findings of a possible right hilar mass on the chest radiograph. And she subsequently had a CT. And I think what you can all appreciate here is markedly dilated, tortuous mediastinal vessels that are coming from the descending aorta. And there's a very large aneurysm here in the anterior to the right hilum, which was accounting for the radiographic possible right hilar mass. There's also a partially thrombosed aneurysm here in the subcarinal area. And you can see here that the right interlobar artery is really radiopaque, filling with contrast from the systemic circulation. And even with multiple reconstructions, it's very difficult to appreciate where the connection is between these dilated tortuous bronchial arteries and the right interlobar artery. So this patient went on to have bronchial artery or bronchial angiogram and embolization of this large aneurysm here anterior to the SVC. And so this is, and just to complete, the lungs are completely normal in this woman. So this is probably a rare case of congenital bronchial arteriovenous malformation. These are quite rare. The majority of dilated bronchial arteries in the mediastinum, are due to chronic lung infection. They don't get this large with chronic thromboembolic pulmonary hypertension. Other causes are proximal interruption of the pulmonary arteries with in patients with congenital heart disease and conotruncal abnormalities that develop MAPCAs. And there are some other causes like Takayasu and Osler-Weber-Rondeau. But this patient had nothing associated, and so this is probably a congenital type of arteriovenous malformation. It's been given multiple names: bronchopulmonary shunts, bronchopulmonary arterial anastomoses. And the anastomoses can be to the pulmonary artery or to the pulmonary veins. They're said to be more common in men and most common on the right side. And they can occur in the lung or in the mediastinum. In the lung, they present with hemoptysis, and in the mediastinum, they present as with compression of other structures or rupture and symptoms of acute aortic, that simulate acute aortic dissection. So they are treated when discovered because of their risk of rupture, and treatment is either surgical or with bronchial artery embolization. So this is a very rare entity. Any questions about that?
No, very cool.
You guys still hear me?
Yeah.
Okay. So I had a few other cases that kind of complete this. It seems like ever since I saw that particular case, I don't know if I'm paying more attention, but I've seen now several. This was another patient, 58-year-old man who had a coronary angiogram and had left circumflex artery to bronchial artery aneurysm or fistula identified. So again, he came for coronary CT, and you can see multiple dilated bronchial arteries, and you can see enhancement or communication to the right interlobar artery. And there are multiple communications on both sides to the pulmonary arteries from these dilated bronchial arteries. I just have a mediastinal reconstruction. Sorry, wrong one. Just so you can see these communications. So here the patient was asymptomatic. He had a cardiac MR. There was no significant shunt perceived on phase contrast imaging, and he has decided not to have any further investigation. And again, this patient, you can see there was no abnormality within the pulmonary parenchyma, and we weren't able to do pulmonary or a CT pulmonary angiogram to exclude CTEPH, but the right ventricle is normal in size. There's no right ventricular hypertrophy, so there's probably no significant, there's no CTEPH here as a cause. Also no known congenital abnormalities like Osler-Weber-Rondeau. And the next is a 65-year-old. This is all within the last 6 months, showing again similar findings on CT, on a cardiac CT. He came in with atypical chest pain, and there is non-obstructive coronary artery disease, but the striking abnormality again is these dilated bronchial arteries throughout the mediastinum. Here we could not perceive any connection with the pulmonary arteries or veins. He had a CT of the thoracic aorta. He had a CT pulmonary angiogram, and we couldn't see any connection. The only thing that we could see was on the lung windows. These dilated bronchial arteries seem to be going out into the fissures. I don't know if you can perceive these, but they all seem to be heading out to the through the fissures into the pleura. And there's no fistulous connection to anything that we could see. So just another case here. This one's a bit more of an enigma because I don't see a connection with pulmonary arteries or veins. And then finally, the more usual case that we see with dilated bronchial arteries, just one of the more common causes. So multiple, again, dilated bronchial arteries. But in this particular patient, we see evidence of significant bronchiectasis, cystic bronchiectasis throughout the right lung. So there's, probably the most common cause of dilated bronchial arteries in the mediastinum. So that's all I have. Collection of dilated mediastinal bronchial arteries.
Perfect. That's great. Thank you so much, Carol. Any questions or comments, guys? All right.
There's also a really good paper in Radiographics in 2014 on this, on bronchial arteries.
Perfect. Thanks. Let's see, Dr. Lidmanovich, I don't see her, so we can start going through her slides like we did last time. Let's see. Actually, we get down all the way to case number 4, I believe. So let's just go there. I have not seen the cases, so we'll try to get to them together. Yes, we did see this one. And I think we saw this one as well. So case 4. Let's go to case 5. Okay. And again, guys, please do comment, participate. I have yet to. I have not seen these cases, so we'll play it by ear here. All right. So case 5. Sorry. Okay. 57-year-old man with acute chest pain and a family history of coronary artery disease. Okay, so we have 3 axial views of a gated cardiac exam, mid-heart down towards the inferior wall of the heart. And then we have a curved planar reconstruction here of the LAD, looks like. The first thing we see is this large structure, partially enhanced in the right AV groove. Goes down, this closer to the sinuses, and then goes down towards the base. Communicates here with the RCA, so this looks like a partially thrombosed large right coronary artery aneurysm, I believe. There may be a little bit of plaque here. There's maybe some calcifications here in the posterolateral branch here, and definitely here on this LAD there's some mixed calcified, non-calcified plaque, proximal segment. Probably some significant narrowing there in this relatively young man actually to have this much disease and a coronary aneurysm. So let's see. So severe ostial stenosis of the right coronary artery. I think we can all agree with that here. Subsequent dilatation and eccentric mural filling defect of partially thrombosed aneurysm. All right. There you go. Distally, the enhancing lumen narrows, and there's creates mass effect on the right atrium, and there's also moderate stenosis of the proximal LAD. They did a volume render image here. You can see the narrowing of the RCA, just a wisp, if anything, here, and then the focal dilatation here. Not sure why they did this imaging, but looks cool. All right, so differential diagnosis. What are we thinking? Atherosclerotic aneurysm, congenital aneurysm, Kawasaki, pseudoaneurysm, and saphenous vein graft, bypass graft aneurysm. Anyone on the call that wants to take a guess? All right, I think we can all agree here, right? There's plaque. Most common cause of aneurysms in the developed world is atherosclerosis. So we're gonna go with one, atherosclerosis. Speaking of Kawasaki, I don't know if you guys saw, reported today, there's 15 kids with Kawasaki's were admitted today in New York. They think there may be some relation to the coronavirus. So 15 kids admitted today with Kawasaki's in New York City. Atherosclerotic aneurysm, that's a diagnosis. So aneurysm, coronary ectasia, segments that are 1.5 times larger in diameter than the adjacent normal segments or the largest normal appearing coronary artery. There's some diagrams there to understand that. Aneurysms involve at least less than 50% of the affected vessel length. Atherosclerosis is the most common cause, like we talked about, coronary aneurysms. The right coronary, much more commonly affected than the LAD. And just like plaque, is going to